Well, it's a pleasure to be here, and I don't know what you are expecting with this title, but, I will have to translate that. So I discussed with Michael whether I could change it. He said, no, this is the title. Everything starts with how to, and then right. So okay, so I don't understand that, so I don't know what I'm going to talk about. I say, well, this is what I'm going to talk about: is how to improve diagnosis and access to treatment for tuberculosis in low-resource settings, which is one of the aspects of my research work. Sorry, I'm in this corner because this mouth is a little bit short. Very often in this country, people ask, is TB still a problem? Yeah. And you will hear probably in the next few weeks that London is actually the capital of tuberculosis in Europe. It's still one of the centers that has reported more cases of TB than anywhere in Europe, except for the former Soviet Union. But it is in very restricted groups. But TB in other countries is still a major problem. In fact, in some places, as you see there in Ethiopia, is the main cause of hospital admission in adults and the main cause of death in adults. And there are now more than 9 million cases every year. These are new cases. And nearly 1.5 million deaths. So it's still, and it's a disease that affects mostly adults. So often is neglected, or it was neglected for many years, because priority was given to children for many other good reasons, but only until the 1990s it was recognized it was a major problem. It's also frequently associated with HIV that changes quite a lot of the presentation of the disease, so it makes the diagnosis more complicated. And there are some countries that are especially affected by them for several reasons. For example, you can see China and Brazil among the BRIC countries still affected by TB. And it is mostly because of the large population they have. So they contribute to a large number of cases, even though in terms of the proportion of the population, the attack rates are a little bit lower than in other places. But as you may suspect, many countries in Africa have a large number of cases and high burden. And then the former Soviet Union, when the system collapsed, then all the treatment centers, all the system was disorganized. And there's a major problem of drug resistance to most of the normal treatment for TB in that area. So WHO declared tuberculosis a pandemic. It's an epidemic that crosses borders. And it's a public health, an international public health emergency. So that's why, if you see internationally, there are many now organizations that fund the control of tuberculosis, the Global Fund, for example, because it's one of the main priorities. It's also a disease that is associated with poverty, yeah? Because people who are malnourished are more susceptible, people who live in poor conditions, poor environmental conditions are more likely to acquire it. People who are poor have less access to health services, though, and then they are more likely to have other infections that make them more susceptible, and so on. And at the same time, it's a disease that has a lot of stigma. Feces, or somebody who had the black fever, the white fever, or tuberculosis is often ostracized. In some countries, if a woman has had tuberculosis, possibly will never get married. So it has quite a lot of stigma. So the patients with TB very often come from remote locations. They come late for diagnosis. They have lost earnings or are unable to work, so they have very poor social economic resilience. And the diagnosis is the same. It has been the same, nearly the same for the last 100 years. And it's 100 years of sputum small microscopy. So for that, you take a sputum sample and you put it stain it and put it in the microscope. And it's a technique that is available in nearly everywhere in diagnostic centers, and you only need a microscope. It has a good specificity. Yeah? So it is, if you find the bacteria, it's likely to be TB. but it has very poor sensitivity. So you need many samples. You need at least 3 samples. So then we collect the first one when the person comes to the clinic, and one sputum sample. And then you ask them to come the next day. And before they get out of bed, they choose, when you get early in the mornings, if you have been smoking the night before or drinking, this is the time when you really put a good sputum. That's the one we really like. Yeah? We doctors like, oh, this is a very nice sample. Very, very good. Yeah. So that's the we collect it. We call it the morning sample. And then when the patient comes to the clinic again, we ask him for another sample. So it's 3 samples. Yeah. And there's quite a lot of misunderstanding on that. Patients say, well, why are you asking me for more? I already gave you 1. So you do your job properly. And it's that type of thing. So that really means that just collecting the samples takes at least 2 days, and often takes more than 2 days because people are asked to bring that very good sample, morning sample 3 times, 3 consecutive times. That really means there are 4 days only to submit the sample. So the first thing then is smear positive is very important because then you have access to treatment. Treatment is free, often decentralized. But then then you were required to have 2 positive samples, and the samples had to have a lot of bacteria, a lot of bacilli, more than 10 bacilli. And then after all of that, we know that on average it finds 50% of the patients to have TB. So we miss half. So it's not trivial. So if you say, well, go to the clinic here, do your HIV test, oh yeah, we miss half. If you come back in a few weeks' time, you wouldn't accept that. So it's very poor quality diagnosis. And many patients then, also, they don't come the next day. You say, we are going to screen you for TB, and say, no, I don't have TB, so they don't come back. Sometimes 10, 20%, they don't come back the next day. Okay. So the first task we had, maybe 10 years ago, was how do we improve the smear diagnosis of TB? So we decided then to start with just to look at the data we had. So that's the first type of study design that we use routine surveillance data. So it's something that in Ethiopia there are hundreds of thousands of cases. We review 47,000 smears from patients. Yeah. And we organize them according to the order they have been collected. First smear, the morning, sputum, and so on. And we look at the percentage of patients that were abandoning the service and how many of them were identified by the first, or the second, or the third. Very often because the third one, people say, well, it's not so useful. So the first specimen identified 92% of the patients who have smear positives. The second one, 7% more. And the third one, only 1%. Which is something that is very important. So then the third smear, this is the paper, the smear identifies very few additional cases. And that really means that if we are losing 10% to ask the patient to give the third smear, then we are losing 10% just to gain 1% in sensitivity. So it's illogical, but that's the way it's been done for 50 years. Okay. So the second thing was then, do we really need 2 positive smears? So people say, well, only 1 smear, no, take more, and then until you find the second one. That really meant a lot of work. But there is no real evidence of why was that needed. And it was really done, a study done in India in the 1950s that decided that the combination of 2 positives was the one that had better specificity. Not sensitivity, better specificity. So we then went on to do a case series, because people would survey and say, well, the data has a lot of limitations. You don't know how the sputum were recorded. Maybe the ones that were positive were recorded. Maybe the first one was negative, and the next one just recorded negative, and so on. So we prospectively did a case series. Yeah. So this is the second type of study design that we use. And then consecutively, we enroll patients, and we look at the yield of the first, second, and the third smear, exactly the same, and then check at the number that we lost every day. And then we obtain the same results. Yeah. We said, well, 2 smears are sufficient. We lost about, on average, internationally we know now you lose between 1 and 5% of those patients. And again, this we publish. So then the next thing is that 10 bacilli. Yeah? And if you look at a smear, you really need to look in the microscope for 10 minutes. And you have to do 60 smears in a day. That's 600 minutes in the microscope. And then the technician goes inside and comes out 1 hour later. And he said, well, that's 60 minutes. Yeah? So what happened with the other 540 minutes? You should have been reading this. Yeah? I go, no, it's done. Yeah? So very often in practice, the technicians really look for a few bacilli and then declare them positive. So let's say, well, let's look systematically whether this is really necessary or not. So we did then cross-sectional survey. Yeah? So we have changed a little bit the design. But then you compare smear microscopy against a gold standard. That is culture. Yeah? Culture is expensive, takes a long time to give you the results, and is not useful to manage the patient, but it's useful to evaluate the diagnostic test. Yeah? So we did 3 studies in Nigeria, Ethiopia, and Cameroon, where we looked consecutively to all these patients, and we found that if you find one bacilli and blindly do the analysis and compare them later with the culture, one smear positive with one bacilli is enough. So that also finds a high sensitivity, because before, if you had 9 bacilli, you still had to say it's negative, or it's scanty, and wasn't considered positive. So we say, well, if one bacilli is positive, and it's really positive, then you could, then I find many more, many more as positive. So again, this is the paper for that. So you think, well, does it make any difference? And you say, very often people are not so enthusiastic with blood, because this is low technology, and you say, well, there are little tweaks on these things. But if this is what we have at the moment, that we have 3 sputum samples, and we don't need this one, so we have reduced the workload by a third, and we don't need to have 2 positives. Okay, 1 positive, then you don't have to examine the second one. So possibly it's only 1. And if you don't have to have 10, but only 1 bacilli, then you find many more. So in that sense, it is quite important for the management of the workload of the laboratory. There's about 250,000 laboratories in the world doing this work. So, but it's still a spot and morning sample. That still requires 2 days, isn't it? Because the patient comes today, has to come to the other sample tomorrow. So how can we do this? And this is the standard way that we collect samples, for the spot, morning, spot. So we said, well, could we front load this collection? Yeah. So this is what we say. Well, you know, that second spot sample is the same as the first spot sample, really. Could we just move it to the first day? Yeah? You collect, instead of spot morning spot, you collect spot morning. It's the same sample. Yeah? And remember, this is 50 years of inertia. There's a lot of experts there that even so moving this smear like that, this photo like that, say, oh, no, how do you do? Why are you doing this? I said, well, let's see. And then we didn't tell them, but if we were discussing at the time we could get rid of the third one, that means that we are getting rid of that one, yeah? That one that was in the second day. So, if 2 samples are needed, we could then end up with spot, which is in 1 day. Yeah? Which then, of course, we will try to say that these samples on the spot are the same as the one that is the morning spot, or the very good one. You see, remember the one that I said for tomorrow morning, yeah? So that's the one I would like to, and people will be very reluctant to get rid of. Yeah? Right, so we have done surveys, and we have done cross-sectional, we did cross-sectional surveys for this, yeah? So we enrolled patients, and we did something that we said, well, let's collect 2 spot samples, 2 on the first day and 2 on the second, yeah? So usually it would have been spot, morning, spot, but then if we had 4, we could analyze the first 3 or the traditional 3, couldn't we? Yeah. So you could compare these two, and then we did, and then we compared them, and then we said probe loading small microscopy is a very good opportunity to optimize these services. Yeah. It's trivial, but it seems, and then there's 3 publications again from there. And people say, well, look, if you know that you're going to look 3 samples, there's a learning process in the patient. So the third one, people are either tired or people that know that the others are positive. Even though we were assessing the smears blindly, not the microscopies, but then we were blinding the results from the previous results. So the microscopies were unaware of the other results. Yeah? So they say, well, still could be some bias. So you realize that the gold standard really is a clinical trial. Yeah? And that really 50 years of doing the same thing is not easy to change. Yeah? Not easy to change. And you have a lot of experts who have a lot of experience of how you should do it that way. And they know you should collect in the morning at that time. So it's very difficult. So what you need to do really was, they say, was a double-blind, randomized, multi-country, non-inferiority clinical trial. So we went on to do that. We took in 4 countries, and familiar maybe to you now, Nigeria, Nepal, Yemen, Ethiopia, and Brazil. Brazil at the end didn't have enough samples. So we enrolled 7,000 patients. And we randomized them, with this clinical trial, we randomized them. 1 week, all the laboratories in the 5 countries were doing spot, morning spot. The next week, they were doing spot for morning. Yeah. And all the samples were analyzed blindly, and it was all this randomized. It was block randomized to have equal numbers. And it was powered to 90% and so on. All these technical steps we need to do to achieve credible results from the biological perspective. From medical community, this is the gold standard. So this is what we did. So we said, well, are they equivalent? And the other thing is that we are collecting these. If you analyze only the first 2, are they also equivalent? Yeah. Or not? So an equivalent study, if you remember, it requires much larger sample size, and if you want to show that one is better than the other. So this is an equivalent. So what we found is that even in these studies that were under research conditions, where there were teams of people asking people to come the next day, by the time you ask for the third smear, about 8% of the patients, 10% had lost them. Yeah. But if we ask them to bring the spot morning, the losses on the third smear were still 6%, but the second one we only lost 2%. So the losses were much lower. So if you were going to use these schemes, then using 2 smears it would be much more important than because you will lose many less patients. And then the result was, after 2 years of running everywhere in the country, that there was no difference between the 2 studies. Yeah. So those are the papers. And at the same time, of course, we have to use the funds effectively. We evaluated some new microscopes that were fluorescent microscopes that are now the most recent technology, the microscope. So, of course, for an academic, this is very pleasing. Papers in high impact journals, but the WHO guidelines are very difficult to change. Yeah. And especially these days, national control programs will not move any finger differently unless WHO has approved it in the guidelines and is stamped and it comes and it is accepted in the country. So, okay, so you can produce any evidence you want, but unless you engage in the process of policy making, you don't get anywhere. So, how to engage in that? So you have to engage in policy making. Yeah? And in our case, is WHO and national coordinators for national programs. So you have to whisper in the ears, and you have to have some beers together, and do a lot of advocacy, saying, look at this is there is no profit here, there is no commercial profit, but it could be useful. So you go to conference talk, conference calls, and recruit champions. So we had a lot of former patients that say in the conference will stand up and say, you know, I went through this diagnosis, I spent so much money, and so on, and then this will be very useful, and so on. So, and then you engage in expert committees in medicine, you review the evidence, and then you go together with colleagues who are experts in the same field to discuss what the evidence is. So you need to understand the system, because otherwise if you come and you shout and everybody will say, well, yeah, and then you get it. Okay. And then you suggest it to the national program managers. Often you will see like the policies are changed at the international level, but it will take 20 years to trickle down to national level. So there is also mechanisms to translate international guidelines to national policies. So the next step here is to do systematic review, and I think somebody from the school here is involved in a lot of systematic reviews. We did some on frontal smear microscopy, and those were the ones that were submitted to WHO as evidence that these schemes worked, that they were exactly the same as the traditional scheme for 50 years. So it took only about 8 years, but then these are the new WHO policies. Yeah. So there have been 5 policy changes in the last 5 years, and now we are in the process of translating this into national guidelines, national policy. So you Google them and you can get them everywhere. So are we done? Well, only 45% of cases attend the diagnostic centers. So even though we optimize diagnostic microscopy, we lose half of the patients before because they don't arrive there. Yeah. So why is that? Well, you know poverty, you know stigma, possibly expenditure, lack of transport. So these are social issues that we often, from the biological perspective, we lose sight of that. And so we try to improve the performance of the test, but we realize that there is a social issues that we have neglected because people don't access the services. So we then did surveys and case control studies. You may be disappointed, but we also did qualitative studies. Yeah? And those were really first to describe how poverty delayed the presentation of the patients to the services. Yeah? And also to identify what are the factors that create much delay on patients attending the services. Yeah? So we did this with quantitative cross-sectional studies. And also then we found that most patients come from rural areas, and most of them come accompanied, which really means that you have twice the price of transport, twice the price of accommodation, food, and so on. Many of them have sold assets, especially cattle or land sometimes, to be able to afford these services. And they were surprised by the duration of the diagnostic process. They thought you come one day, blood sample, you have anemia, and then you go away. And here they are asking you to stay for 3 days. So it is quite a long time. And then after that, sometimes they say, you don't have TB, so you still don't know what you have, so you have to continue doing other things. So we also did in-depth interviews and focus group discussion. And of course, this is where Sally's main expertise comes in. Sally Cuevas from social sciences in the school. So then in Ethiopia and Yemen, especially in Yemen, we have found that there's a lot of underhand payments, because your diagnosis could be very much easier if you add a little bit of money in each one of the steps. But then each one of the steps is registration to get a card, to be seen by the doctor, to submit your sputum sample. There are three sputum samples, the X-ray, looking back to the doctor, and each one of them adds a little bit. So one of the main components of the cost was on the hand payment. And then fear of diagnosis, because if you are said to have TB in Yemen, is really difficult, as I was saying, even to get married, but also to be ostracized, to be excluded even from home. And then staff were also short of time. So they tell you you have an infection, but what type of infection? And you don't have the time to explain to you that there are many different types of infections. And it becomes very unclear because the treatment for TB is free, but the treatment for other diseases, other infections is not free. So some people are saying, well, I got my treatment free, and the other one, no, I have to pay. Why is this? And there is this perception that there is something going wrong, but they don't know what it is. And there are many barriers to attend the services. So the question was, could the service come to the patient? And for that, we would say active case finding. Because if we wait for the patients to come, asking for case finding, and it doesn't come, so we go and find them. Couldn't the service become patient centered rather than service centered? So could we then facilitate the link between the person that's in the house, that maybe doesn't want to leave the house or is unable to leave the house, and the laboratory, which is required for diagnosis? We cannot really make only a clinical diagnosis. So we have done all this. The next step was to do some implementation research. We call them intervention studies. So we have 3 studies which have slightly different models of active case finding. So in Yemen, we started by people who have come to the health center and they are diagnosed by TB. Because of the characteristics of the society, we know that women often are locked at home during the day, and they cannot go out on their own. And also elderly have a problem as well. Transport, Yemen is a very difficult, geography is quite difficult. So we thought, well, elderly women, children, maybe there might be lots of cases at home that never access the health services. So we created teams of male and female nurses that working together gain access to the households of people who have TB. And they asked whether there were any other residents who had symptoms. Then we took the samples out there using the fluoride microscopy the same day, go to the laboratory, process them in the same day, coming back. So with the cars, that which makes it expensive too. Some cars going around into this location. The other study is in Ethiopia, and this was our largest study. These were village-based health extension workers. These are secondary education individuals who live in the village. They are selected by the village. All of them are females. And the starting point is just going house to house, trying to identify people who have cough. And then taking a sputum sample, and then there is a network of motorways, mobile phones again, where linking these health workers with a set of supervisors. And then there is 800 village health workers and 25 supervisors that link the health worker there on the left. These are all the health workers in the middle doing training, and then the motorbikes there and link it to the lab. And then these are two-way communication. If the patient is positive, then she will receive a phone call and she has treatment and she will bring the treatment at home. Simple technology in the sense that it's also only uses the smear microscopy. And then in Nigeria, this is what we started this year, we use also health extension workers. But instead of going there being in the village, because then they only cover a small area, there are teams of small health workers that go from house to house in the slums. And they identify people with cough, collect sputum sample, and then the same system taking it to the lab. And then we use a new test called expert, smear microscopy and expert. I will come back to that one later. So slightly different approaches in the 3 places. So, and then in Yemen, we found that 1 in 10 households had another case. So this is quite a lot. So, and then also in the health services, you find more males than females. in the houses you find more females than males, not surprising. And many people, you go at home, and when you go at home, they say, yeah, I don't have any symptoms, but I want to be examined anyway. So we had to collect a lot of fecal samples from people who were not symptomatic. So, and still we found a few of them positive, but it was really very promising. Life is complicated, because then we had the spring, yeah, and then we have the Arab Spring, and it became an armed conflict, and it became a coup, and we had to interrupt the study. Yeah. So we had 1 year findings, and we explore ways in which we could continue approaches for diagnosis of TB on the conflict, but it was quite taxing to our staff, our colleagues, and some of them were in their houses were bombed. Okay, so it doesn't always go well. When in Ethiopia, there was a very high acceptability of the approach. Patients loved it. Because the health workers don't have any uniform, they are from the village, they accept them, there is no stigma attached to that. And in the first year, before we started this, there were 2,000 cases identified. In the second year, there were 6,000 cases. There was a lot of problems of so many new cases, treatment for all of these, follow-up of these, and so on. It's a good problem to have, but it was so high that external monitors came to see whether it was true or not, because it was very good. So it had a very high acceptability. So much that USAID is now representing became a 40 million investment in 4 of the regions in the country, and it's going to be implemented in many other places. Nigeria, we have only done very few months of the study, and we are going through the struggle of Nigeria, yeah, because the political system is complicated, yeah, from many different aspects. But already we have seen an increasing number of cases, and there are many international to see. They say if you can do it in Nigeria, you can do it anywhere. So this is very important in that sense, yeah. And we may potentially have a higher detection rate than in Ethiopia, yeah. But it was just because of expert. So what is expert? An expert is what everybody was waiting for many years, and it's a new diagnostic test. It's an automated test where you could put the sputum in that little blue cartridge, and after a little bit of digestion, you put it in this machine. Yeah, you can put 4 cartridges at one time, and there's an automated PCR. I don't know if you know what that is. It multiplies the DNA. So it's very sensitive and it's very specific. But because it's automated, it gives you the results in 2 hours. And it's nearly as good as culture, yeah, which was the reference standard, the gold standard. So we say, well, this is great. This is what we have been waiting for years, because smear microscopy detects only 50%. This one detects 90%. So why are we waiting? But it's also falling, yeah, because I think the most important is at the bottom, is the funds. Yeah? Because at subsidized prices, this cartridge will cost about $18. $16 now. If you buy it in this country, it will cost you $200. Yeah? And even in this country, there are discussions whether it is affordable or not, because you can do all that. But not only that, it also requires a computer, which also comes with software problems, with contamination, antiviruses, you need electricity. You need servicing. Yeah, because the machine needs to be serviced once a year. And if I have 5 machines in Nigeria, in the rural area, in the slums, do I have a technical staff from here who would like to go and service my machines? So it's a struggle. It's possible, but the price, yeah. It needs a stable electricity, which we found recently, yeah, electricity. And you say, do you have electricity? Yeah, yes. The plug is there at the back. And you see there is one plug at the back of the building outside, yeah. And then this one, with all the equipment, you will need 6 plugs. So you need extension, electricity. Just put the plug. No, the fuses are not big enough, and then you put everything is now in order. Plug the electricity is gone. You come tomorrow, and you need to have a stable electricity. So then you need inverters and so on. So we have ended up buying generators, and which release petrol and security and so on. It's a very complicated. So, and it's expensive and is not a very low technology test. But it's quite good. It's good sensitivity, good specificity from the performance. It has another problem, and it tells you, oh, this patient has some mutations, and the bacteria may be drug resistant. Yeah, but drug resistant, especially if it is multiple drug resistance, the cost of the treatment is 100 times higher. 100 times higher. And there is no hospital capacity to treat all these cases. So in a way, I don't know if it is good to know, because if you find 100 patients with those markers, genetic markers, only about 10% will have drug resistance. But really that means that we have to culture all of them, do drug sensitivity and so on. So many other things. So we don't have the hospital capacity to treat it. So people are starting to say, oh, don't worry, we will treat them in the community. But can you imagine here in Liverpool 8 saying to somebody, we are going to treat your neighbor with drug-resistant tuberculosis here, don't worry, yeah? People will say, no, that's not acceptable. They could get infected with a bacteria that is drug-resistant. So we have no evidence of how feasible it is, or how acceptable it is to the community, whether it will increase stigma or not. I guess it will. And what are the support services that you require? If you have drug-resistant TB, are you going to go to the market, or you need services to help you to get even basic food, things like that? There is very little evidence for that. So this new test is good from the point of performance, but from the point of all the other issues that he's bringing up is different. So where next? Yeah? So this is where we are at the moment. So we need to really develop streamlined services that incorporate these new technologies into active case finding strategies. Yeah? But that are close to the community, but we should do them from a perspective that this should be the development of services that are equitable, and also as important are cost effective. Yeah. So we are doing some research on pooling, sputum, and so on to reduce the cost of the use of these tests to about a tenth of what it is about. So this is where we are going next. And also, we need to do qualitative and feasibility studies of how do we treat MDR-TB in the community. We know that it's not possible to treat them in a hospital. In fact, in the former Soviet Union, when the patients are treated in the hospital, they are more likely to develop drug resistance. So it's not good to treat them in the hospital. We don't know how to treat them in the community. That's the other side of the coin. So we need to create that evidence how to do it properly. And then we have to insert them to the mainstream services, because if there are 10, 15% of the cases, there are not a few of them. It's quite a lot. So again, now we have all these studies we are going back to. This is some of them to start to create systematic reviews. Okay. Having talked about children. Yeah. And we know that there are many children with TB. Yeah. The diagnosis is very difficult. In fact, there is very little agreement of how to make the diagnosis. There are 14 different algorithms. That means if a child with diagnosis somebody who has this and this and this and that, and another says, no, it has A, C, D, and another one says another definition. So quite a lot of that is the reason why it's very difficult to find how many cases of TB are there. So we have been working together with the develop consensus diagnostic definition. But there are very few reported. And when it is properly done, up to 25% of the cases of TB could be children. So it's not, again, it's a very large amount of cases that we never have them reported in the statistics, so it's neglected. But I think that's for a second lecture. Hey, I'm going to leave it there. Just have to say thank you to many, many colleagues, because this is not something I do on my own. Sally in the school, Mohammed Yassin, my previous research fellow, and then other from the PIs in the different countries. And again, there's a lot of lab staff that is doing a lot of work. These are our funders.